Hello? Yes.
Yes. Okay. Okay, next question.
Okay, question 4.
Mhm.
Uh, a 25-year-old woman, gravida 1 para 1, comes to the physician because of almost continuous vaginal bleeding since 5 days. She underwent cesarean delivery because of breech present in her 40 weeks of gestation. She has had no difficulty in breastfeeding. She is afebrile. Approximately 5 ml of blood is seen in the vagina. The cervix is closed and the cervix is closed and the uterus is firm, approximately 10 centimeter in length. Hematocrit is 37. Which of the following is the most appropriate next step in the management? Only 5 ml of, is it low Kia?
Well, probably that's what I'm thinking.
Okay.
Okay. Is observation. Vaginal discharge, lochia, following delivery may last during the period um, of the puerperium for 4 to 6 weeks. So from delivery to like a month and a half. The early discharge term lochia rubra contains blood and may last for up to 10 days. Lochia slowly becomes less bloody, a more serious term lochia serosa, before finally becoming white to yellow in color, and term lochia alba. These patients stable hemodynamic normal hematocrit with a small amount of blood identified on exam as suggestive of lochia rubia. More significant bleeding may suggest delay or prolonged postpartum hemorrhage, and should prompt an immediate evaluation. Common causes of postpartum hemorrhage include uterine atony lacerations, trauma to the uterus, cervix, vagina, introitus, retain products of conception, and coagulopathy. Okay, next.
Yes. A 27-year-old woman, 7 weeks of gestation, is admitted to the hospital for ruptured appendix. During observation, one ovary is inadvertently removed due to extensive adhesion from previous operative procedure. Pathologic examination. Pathologic examination of the ovary specimen shows a corpus luteum cyst. Which of the following is the most appropriate next step in the management?
Ready?
Yes.
We see progesterone supplementation until 10 weeks gestation. And the corpus luteum develops from the follicle following ovulation. Its primary role is to secrete progesterone from luteal cells, and the progesterone maintains the endometrial lining, prepares it for an embryo implantation, and decreases uterine contractility in support of the developing embryo. Following implantation, the corpus luteum continues to secrete progesterone for the first 10 weeks to maintain the pregnancy. After this time, the primary secretion of progesterone becomes from the placenta. The corpus luteum is maintained by HCG from the placenta. After the placenta begins secreting progesterone, the corpus luteus degrades. However, without the corpus luteum secrete progesterone, as in this patient, spontaneous abortion may occur. And therefore, in this patient, supplementation of progesterone until 10 weeks is appropriate. No treatment is indicated is incorrect, as failure to supplement progesterone that would have otherwise been generated by the corpus luteum can lead to spontaneous abortion. Okay, next.
A previously healthy 18-year-old woman comes. A previously healthy 18-year-old woman comes to the physician because of 2-day history of vulvar pain. She is sexually active. She is sexually active and is 3 male partners. They use condom inconsistently. Examination shows a tender non in examination shows a tender non-indurated ulcer in the right labia major that bleeds when touched. Which of the following is the most likely causal organism? Non tender non
Ready?
Yes.
So, Eosinophilus ducreyi, variety of STI may cause formation of tender genital ulcer. These include herpes and chancroid. Herpes is caused by HSV, and chancroid is caused by Haemophilus ducreyi. In contrast, lymphogranuloma venereum by Chlamydia trachomatis, syphilitic chancre by Treponema, and granuloma inguinale by Klebsiella, um, or Kalimata. Oh my goodness. Are non-tender. So Kalimata is kind of like Klebsiella granulomatus. The cause organism of painful genital ulcers can be distinguished clinically on the basis of ulcer appearance. For example, the ulcer of chancroid is exudative and accompanied by significant inguinal lymphadenopathy. The ulcers of herpes are round and shallow, and some vesicles may be intact. Okay. Calymathobacterium granulomatis is the causative organism of granuloma inguinale or donovanosis. The ulcer of granuloma inguinale, also called donovanosis, is red, friable, and induces additional ulcers on oppositional skin. It's painless, not painful. Okay, next.
A, a previously healthy 27 a previously healthy 27-year-old woman is brought to the emergency department 20 minutes after a sudden onset loss of consciousness. 20 minutes after sudden onset loss of consciousness. She has a one-day history of temperature 103 degrees Fahrenheit, vomiting, watery diarrhea, rash over her face, trunk, and arms. Her last menstrual period 5 days ago. Her last menstrual period 5 days ago. She routinely uses tampons, and her temperature is 103 degrees Fahrenheit. Respiration 30. Palpable systolic blood pressure is 70. She shows erythema on the conjunctiva and the pharynx. Pelvic examination shows 10 to 15.5 centimeter ulcer in the vaginal mucosa. Culture scraping show Staph aureus. Which of the following is the greatest risk of mortality? Following complication. Is it toxic shock syndrome?
Yeah, probably toxic shock syndrome. I'm between A and B. Hemorrhage. Hemorrhage, toxic shock syndrome. Hmm. Okay, ready?
Yes.
Okay, so it's ARDS. A staph aureus produces exotoxin called toxic shock syndrome toxin. TSST1 is a superantigen that triggers the massive production and release of cytokine, including IL-1, 2, interferon gamma, and TNF alpha, leading to toxic shock syndrome. Toxic shock syndrome is associated with prolonged continuous use of tampons or nasal packing. TSS present with fever, diffuse macular rash, red rash, distributive shock caused by endothelial dysfunction causing um, leakage of fluid from vascular space to the interstitial space, along with diffuse vasodilation. The resultant shock and inflammatory state lead to multi-organ failure. Manifestation from GI system include abdominal pain, vomiting, diarrhea, and liver failure. Cutaneous involvement may present as a mucous membrane rash in addition to diffuse erythroderma and sloughing. Renal failure manifests with increased creatinine concentration, electrolyte derangement, and low urine output. Acute anemia and DIC may occur. Neurologic manifestation may include encephalopathy, confusion, seizures. ARDS is serious complication. ARDS characterized by diffuse inflammatory lung injury and results in dyspnea, hypoxia, respiratory failure, which may require mechanical ventilation. Patients with ARDS are critically ill and mortality is increased. So it's not hemorrhage, it's unlikely complication of TSH. The resultant hypotension from TSH is not because of hemorrhage or hypovolemia. Rather, it's the result of cytokine and toxin mediated endothelial dysfunction, um, leading to distributive shock. Hepatic failure and renal failure are potential consequences of TSS, secondary to hypotension and hypoperfusion, resulting in end organ damage. However, the risk of death from hepatic and renal failure will be less than ARDS. Pulmonary EE is not a complication of TSS. Okay.
Okay. A 42-year-old a 42-year-old Nali gravid woman comes to the physician because she has been unable to conceive for past year. She also says she has had hot flashes daily and vaginal dryness. 2 years ago, she was diagnosed with cancer in the right breast, underwent lumpectomy, sentinel node biopsy, 4 cycles of chemotherapy followed by radiation therapy. There has been no evidence of recurrence. She has not had a menstrual cycle since beginning of the second cycle of the chemotherapy 18 months ago. She is in a monogamous relationship with a male partner, has frequent unprotected sexual intercourse. She is 5 feet 4 inch tall, weight is 86 kg, pulse is 80 per minute, respiration 10 per minute, blood pressure 100/60. Examination of the right breast show well healed lumpectomy scar. Examination of the left breast shows no abnormality, and the abdomen is soft and non-tender. Pelvic examination shows vaginal atrophy with no vulvar, vaginal, or cervical lesions. The uterus is normal size. And there is no adnexal tenderness. Which of the following is the most likely cause of this patient's infertility?
Like,
Okay, yes.
so it's hypogonadism. An ovulation can be caused by pregnancy, PCOS, abnormalities, or immaturity of the hypothalamic pituitary ovarian axis, menopause, premature ovarian failure, inadequate nutrition, chromosomal abnormality, thyroid disorder. Other causes of infertility include fallopian tube blockage, sperm hypomotility, inability of sperm to penetrate the coronal radiata of the ovum, structural abnormalities of the uterus, thyroid disorder. Chemo and radiation therapy can be toxic to the ovaries and cause premature ovarian failure. Premature ovarian failure is defined as the depletion of or dysfunction of ovarian follicles with the associated cessation of menses in women under the age 40. While this patient is above the age for this definition, she likely is experiencing early onset menopause secondary to chemo-induced damage to the ovaries, resulting in ovarian follicle loss or dysfunction. Menopause is characterized by lack of ovarian estrogen production, resulting in manifestations such as vaginal atrophy, hot flashes, and infertility. Okay, next.
A 32-year-old primary gravid woman, 36 weeks of gestation, counts for routine prenatal visit. Blood pressure normal, examination show fundus 37 centimeter, so 37 centimeter. Fetal heart tone are hard at the mid abdomen and rate is 141 normal. Deep tendon reflex are brisk. There is no fetal edema. The cervix is 50% effaced, 1 centimeter dilated. The vertex is at -1 station. During pelvic examination, the patient feels a sudden dramatic movement and her membrane rupture. A large gush of clear fluid is seen. A fetal heart rate is 144 per minute. Cervical examination shows no change in the dilatation or effacement. She begins to have painful contraction that every 6 to 8 minutes that lasts 45 to 60 minutes. An electronic fetal monitor is internal pressure catheter is applied. Fetal heart rate tracing is shown. Which of the following is the most appropriate next step? Okay.
Okay, so the answer is observation and continued monitoring. Normal labor and delivery typically occurs after 37 weeks gestation, with the onset of contraction associated with cervical dilation and the rupture of membranes. Okay. Labor that begins prior to 37 is referred as the preterm labor, and rupture of membranes prior to onset of labor is referred to a premature rupture of membrane. So it has to be contraction, dilation, and rupture of membranes. Okay. Following the onset of labor and rupture of membranes, labor continues to three stages. The first stage encompasses the start of labor, contraction, and cervical change until completion of the cervical dilation and effacement. The second stage includes the time from complete dilation, cervical dilation to baby birth. And the third stage is delivery of placenta. First stage of labor is divided into latent and active stage based on the degree of cervical dilation. With the active stage begin after 4, so 5 to 10. During labor, it is pertinent to monitor the fetal heart rate, which provides insight into fetal well-being. Healthy fetal heart rate is 110 to 160 minutes with 6 beat per minute to 25 beat per minute, I guess, for variability and spontaneous acceleration. Okay, intermittent early and variable deceleration can also occur during the normal process of labor. as a result of head compression and umbilical cord compression, respectively. Tachycardia and bradycardia, undetectable variability, and late deceleration indicates. um, so early and variable decelerations are normal. Late deceleration indicates fetal distress, none of which are exhibited in this fetal heart rate ratio. Tachycardia, bradycardia, and late decel. Okay. Therefore, as this patient has begun labor, experienced rupture of membrane, and demonstrates no sign of fetal distress, observation and continued monitoring is the normal, is appropriate. It's not immediate C-section is indicated, for example, in cases of fetal distress, failure to progress, placenta previa, uterine rupture, critical maternal illness, and impeding maternal demise. Okay, okay.
Next. 4 weeks after total vaginal hysterectomy for cervical dysplasia, a 57-year-old woman comes to for follow-up. A pathology report confirms that the presence of CIN3 with a surgical margin clear of disease. Which of the following is the most appropriate recommendation for future screening for recurrent squamous cell intraepithelial neoplasia in this patient?
Okay.
Okay.
Ready? Okay. It is, oh, pap smears annually. Did not see that one coming. CIN3 is a high grade cervical lesion with increased risk for progression to cervical cancer. Cervical cancer is classically associated with infection with HPV, like high risk strains. Risk factors include multiple sexual partners, smoking, immunosuppression. Screening pap smear are recommended every 3 years in women 21 to 29, and every 5 years with HPV co-testing in women 30 to 65. Oh, wait. So the pap smear is 21 to 65, and the HPV vaccine is 9 to 45. Okay, got it. Abnormal pap smear cytology results are most commonly evaluated by colposcopy, which allows for visual assessment and biopsy of abnormal lesion. CIN3 disease requires excision via either loop, like the lip procedure, or gum biopsy of the cervix, also known as cold knife conization. Hysterectomy is performed for recurrent or persistent cervical dysplasia. This patient remains at risk for development of um, cancer given the presence of CIN3 on her uterine pathology and requires yearly follow-up with pap smear of the vaginal cuff to screen for the recurrence of dysplasia. I'm confused. We had one question before like that, and it was like if they remove
Yes,
the uterus, then there is no need to do pap smear. But why here there is need to do pap smear? They remove the uterus.
that is confusing. Yes, we have done similar type of question what you have told, but I don't know why.
Mm,
Is it like these ladies 57 years old? If she is on that question, is there any like age barrier? Like above 65, you don't need to do anything.
okay. Okay.
I don't know actually. I can't say you.
It says no further testing for this condition is incorrect as this patient remains high risk for recurrence of dysplasia given her high grade lesion on pathology. She should continue to receive annual pap smear with further evaluation of it. It seems like they're saying because she had a CIN3, which is like high grade risk for cancer, we still have to do the pap smear
as it is high grade.
because it's high grade. It seems
Even
like
if
that's what.
even if we remove the
Yeah, you do now. You do pap smear of whatever is left there. You know, they remove the uterus. I'm guessing they remove the uterus and the cervix, but the little thing that's left there on top of the vagina, you do the pap smear of that.
okay,
Doesn't make that much sense because oh, and they're saying that because the CIN was also found on uterine pathology, so it had gone to the uterus. I mean, I don't know. I think that's what they mean. That's weird. Okay, next.
on that box like hysterectomy with cervix removed, no screening if negative, prior screen and low risk. If you look
What are
at
you?
that
Which one?
box like cervical cancer screening,
Cervical cancer screening. Okay,
hysterectomy with cervix removed, no screening if negative, prior screen and low risk, then what does it mean?
Barbie is the what they're saying the low risk one. This one she's high risk. So no screening if negative prior screen, but she already had a positive prior screen, and she's high risk. So yeah,
And
okay,
when to like look at the lower the box below when to stop pap testing,
okay. It
age
says, mm-hmm.
age 65 or hysterectomy plus, no history of CIN2 or higher, and three consecutive pap tests should be negative or two consecutive negative co-testing. Okay,
Okay, makes
so
sense then.
now it makes sense.
Yeah, she's less than 65.
That lady is not 65, but hysterectomy plus no history of CN, but there is history of CIN3.
Yeah. Mm-hmm.
So
Mm-hmm.
as so we need three consecutive negative pap tests after that, like as she has CIN. So for stopping the pap, you need three consecutive pap tests or two consecutive. Okay, I got it now. It is written
That,
here.
that's oh Lord. Okay, next.
I will be older after thinking this type of question.
Yeah, that was really specific.
Okay. A 24-year-old woman comes to the physician because of 10-month history of breast tenderness that is worse just prior to the onset of the mens. Her mens occur at regular 28 days of interval, and she is currently on day 26 of her menstrual cycle. Examination shows multiple bilateral firm cystic areas of the breast. Which of the following is the most appropriate next step in the diagnosis? 24. Multiple bilateral firm.
Ready?
Yes.
So easy examination after menses. Fibrocystic changes of the breast occur most commonly in premenopausal women. Patients may present with various sites of breast pain and lumps, which may be bilateral. The condition is characterized by the presence of cysts, stromal fibrosis, and apocrine metaplasia on histology, and is believed to occur in response to hormonal fluctuations during the menstrual cycle. Re-examination after menses may be helpful for diagnosis because the site of the fibrocystic changes should subside after menses, distinguishing it from other causes. On exam, the cyst may appear blue. Fibrocystic change is a benign disease and does not generally convey the risk for cancer. However, it can result in recurrent breast pain. If there is associated discomfort, aspiration can be performed, which may relieve symptoms. Cyst aspiration can yield fluid that is clear, milky yellow, green, brown, which are all benign. Supportive care is also appropriate using NSAID and well-fitting bras. Oral contraceptive therapy has not generally been shown to relieve symptoms of fibrocystic breast disease or cyclic breast pain. So it's not aspiration of the cyst may be helpful for alleviating the pain in patients with fibrocystic disease. However, examination after menses may be helpful to confirm the diagnosis prior to more invasive treatments, such as needle aspiration, and is more reasonable next step.
Okay, can you give me 5 to 10 minutes? I'm coming.
Yes, yes.
Okay, okay. I can't see your screen. Okay, now. A previously healthy 47-year-old woman, a previously healthy 47-year-old woman, gravida 3, para 3, comes to the physician because of 2 week history of excessive vaginal bleeding with the passage of clots. During this time, she has had to change her sanitary pad for every 2 hours. She has had occasional hot flashes during the last 6 months. Her mens previously occurred at a regular interval, 28 days interval, until 1 year ago. Now she has 2 weeks of bleeding every 2 months. She has no history of serious illness, takes no medication. 6 months ago, a pap smear showed no abnormalities. She is 5 feet 5 inch tall, 66 kg, BMI is 24. Physical examination shows no abnormality. Which of the following is the most appropriate next step in the diagnosis? Okay.
So the answer is biopsy. Abnormal uterine bleeding should be suspected when bleeding is irregular, unpredictable, and not associated with signs of menstruation. It may be caused by structural abnormalities such as cervical or endometrial polyps, adenomyosis, endometrial preparation, malignancy, inflammation, or infection of the genital tract, coagulopathy, ovulatory dysfunction. Endocrine dysfunction may be idiopathic. The patient in the question has no signs, no stigmata or history of thyroid disease, coagulopathy, PCOS, ovulatory dysfunction. In patients over 45 who are perimenopausal or postmenopausal, there is a high risk of endometrial cancer. The next appropriate step evaluation will be an endometrial biopsy to evaluate for presence of endometrial cancer. If a patient cannot tolerate outpatient procedure or if the outpatient sampling is non-diagnostic, DNC or hysteroscopy can be performed. Hysteroscopy with sampling allows for a more complete evaluation of the endometrium for polyps, myoma, and structural abnormalities. It is not B, I was confused with that. Measurement of LH or serum testosterone will not be the next step. LH is increased in postmenopausal patients and testosterone is decreased. but neither is useful in the evaluation of abnormal uterine bleeding. In endometrial cancer, the measurement of CA-125 may sometimes be useful for surveillance of disease progression. Wait, so is CA-125 for endometrial cancer, and what was the other CA? Was there another CA?
CA 19-9 breast cancer. CA
19.
19-9
Wait, is that breast or pancreas?
breast and pancreas, as far I remember.
Oh,
What
okay.
you can see in the Google.
Mm, it's pancreas.
No breast cancer. Okay,
No.
okay, may not be.
It's pancreas, cholangiocarcinoma, colorectal, stomach, ovary, bladder, lung. Yeah, no breast cancer.
Okay, I confused with CA 15-3. CA 15-3 is breast cancer. CA
Mm,
19-9 is pancreas, and CA 125 is ovarian cancer, epithelial ovarian cancer, according to
Wait,
first aid.
I thought. Wait, okay, then I'm confused because it says nine. Where is where I read it? I thought the 19, the 125 is endometrial. So is endometrial and ovarian?
Wait, I'm sharing my screen, then you can see it easily. Can you see my screen now?
Let's see. No.
Now,
Yes.
so in first aid, CA 15-3 is or 27-29 is breast, 19-9 is pancreas, and 125 is ovarian, epithelial ovarian cancer.
Okay, there's somebody's wrong because here we're just reading 125 is endometrial. I know the 199 is pancreatic. Hmm, that's weird.
First aid is not probably wrong. Maybe.
Hmm,
Okay, no problem.
okay, here on what's that called? Gemini,
Yes.
it says yeah, it's ovarian cancer, particular epithelial ovarian cancer.
In CA
Um,
125.
Tier 125. Sorry, yeah.
So
Mm, mm,
in
yeah,
in
so
the
I don't.
first aid it has written.
Yeah, so first aid is, I think that first aid is right.
Okay, you can share your screen now.
Okay, let's see, share. Okay, so yeah, I guess this one was wrong. Or maybe it's ovarian and endometrial. I don't know. Maybe. Okay, next.
A 13 year sorry, an 18-year-old woman is brought to the emergency department. An 18-year-old woman is brought to the emergency department 2 hour history after the onset of severe abdominal pain, nausea, and vomiting. During a routine visit 2 weeks ago, uh, pelvic examination showed an 8 centimeter right adnexal mass. Pelvic examination showed an 8 centimeter right adnexal mass. Ultrasonography showed an 8 centimeter 8 centimeter mature cystic teratoma of the right ovary. Abdominal examination shows severe rebound tenderness with guarding in the right lower quadrant. Severe rebound tenderness with guarding in the right lower quadrant. Which of the following is the most likely diagnosis? So,
Ready?
What is your diagnosis? Is it torsion?
Yeah.
Okay.
So it's ovarian teratomas, it's ovarian torsion, sorry. Ovarian teratomas are typically unilateral, can rapidly grow, leading to complications such as pain, hemorrhage, necrosis, um, ovarian torsion. Ovarian torsion describes a condition in which the ovary twists on its ligamental support. The suspensory ligament of the ovary contains the ovarian artery and vein. Um, yeah, if twisted, it can lead to impaired blood supply, resulting in ovarian infarction. Ovarian torsion may occur in patients with normal ovaries, however, this is less common, and an ovarian mass or cyst increases the risk for ovarian torsion. As the size of an ovarian mass increases, the risk for torsion also increases. Malignant masses that adhere to the pelvis may be at lower risk for torsion. Signs and symptoms of ovarian torsion include acute severe unilateral pelvic pain, abdominopelvic tenderness and guarding, adnexal mass, nausea and vomiting. Diagnosis relies on the clinical presentation, but Doppler ultrasound evaluation of the ovary the ovary can be used to confirm torsion. Treatment involves emergent surgery for the torsion of the ovary in an attempt to conserve it. It's not B&D. Pelvic PID typically presents with fever, myocardial and cervical discharge. Cervical and adnexal tenderness may be present in cases of tubovarian abscess. Ectopic pregnancy refers to abdominal implantation of the embryo outside the uterus in an anatomic location that cannot support the pregnancy. It should be suspected in a patient with positive urine pregnancy test that presents vaginal bleeding and acute abdominal pelvic pain in the first trimester. Okay, next.
A 27-year-old primary gravid woman at 31 weeks of gestation comes to the physician because of 3-day history of shortness of breath at rest. She has gestational diabetes treated with diet. She measures her blood glucose concentration 4 times daily, 4 times daily, and her 1 hour postprandial concentration have averaged 144 milligram per deciliter. Ultrasonography at 18 weeks of gestation showed a fetus who had normal anatomy was consistent in size with gestational age. The patient is Rh negative, received Rh immunoglobulin at 28 weeks of gestation. Antibody screening was negative. Her pulse is 88 per minute, respiration 22 per minute. The lungs are clear to auscultation. The lungs are clear to auscultation and percussion. Examination shows fundal height 44 centimeter. The cervix is 4 centimeter dilated, 50% effaced, and the vertex is at -2 and station. Which of the following is the most likely cause of these patient symptoms? Okay,
Okay, so the answer is polyhydramnios. Polyhydramnios refers to excess of amniotic fluid. Polyhydramnios is associated with fetal developmental defects that result in impaired swallowing, such as anencephaly, esophageal atresia, duodenal atresia. Risk factors for polyhydramnios also include maternal diabetes, as in this case, maternal-fetal Irish incompatibility, and congenital infections. Um, okay, as in this patient, the size of the gravid uterus may greatly exceed that which is expected for gestational age. leading to maternal symptoms of dyspnea through prevention of diaphragmatic excursion. Diagnosis is facilitated by ultrasound, which will show an enlarged pool of amniotic fluid. May be used to assess the amniotic fluid index. Polyhydramnios is defined sonographic as amniotic fluid greater than 25. Treatment is supportive, although patients with severe symptoms may be treated with amniocentesis. It is not incorrect gestational age is a cause of discrepancy between the size of the uterus and estimated gestational age. However, it is less likely to lead to such a large discrepancy and is less likely given this patient risk factors for polyandromnios. It is not twin gestation. Okay, yeah, makes sense. Next.
What are the clue you have found? This patient has diabetes, fundal height is 44 centimeter. These two,
Mm-hmm.
like
Mm,
these two is enough
I didn't do it like that. I just deleted the other ones. Like I knew it wasn't an anencephaly because she had ultrasound, so they would have at 18 weeks, so they would have seen the anencephaly. I knew it wasn't twin gestation because same thing. She had an ultrasound, so they would have seen the twin gestation. I knew it wasn't RH immunization. They went deep
because
into explaining it doesn't have RH. They gave immunoglobulin, everything. So they deeply explained the fact that this cannot be RH. And then so I was between incorrect gestational age and polyhydramnios. But incorrect gestational age usually in the questions is not that big of a difference. It will be like that's 31, the other one is 32, like, but it's not that big of a difference. That's how I chose polyhydramnios.
okay, your exclusion method is good.
Yeah, I like to do it when it's usually faster. Like if you can quickly exclude. If you cannot quickly exclude, don't waste your time. Just, yeah. But if you can quickly exclude, then yeah, it's faster.
Okay, a 27-year-old woman, gravida 3 para 2, comes to the physician for prenatal visit. Her last menstrual period was 12 weeks. Her last menstrual period was 12 weeks ago. Her previous pregnancies were uncomplicated. Examination shows closed cervix and a uterus consistent in size of 12 weeks of gestation. Her blood group is AB negative, Rh negative. Ultrasonography shows fetal heart rate. Which of the following is the most appropriate next step?
Between
Okay,
B and C. Okay. So it's indirect anti-gobbling complex. Um, what am I here? Rh negative moms are at high risk for developing anti-Rh antibodies if exposed to if exposed to blood from Rh positive fetus, which most commonly occurs during delivery. If Rh antigens from the fetal circulation enter the mom's circulation, it's possible that the mom immune system will form antibodies against Rh antigen. While this carries no significant complication in the initial exposure, a subsequent pregnancy with a Rh positive fetus can result in severe hemolytic anemia because the antibodies cause hemolysis of the fetal red blood cells when they cross the placenta. The Rh immune globulin acts by binding to Rh positive cells that enter the maternal circulation, preventing the immune system from developing antibodies to the Rh antigen. But it's not always effective, therefore, the best way to determine whether the mom has been exposed to Rh positive blood and subsequently developed the antibodies is the indirect antiglobulin test, which is conducted by combining RBCs that contain the antigen of choice with the patient serum. If the patient serum contains antibodies against the antigen, in this case, the blood Rh antigen, The antibodies will bind to RBCs. When comes reagent or antiglobulin antibodies added, the erythrocytes will, I guess, explode. It's not a measurement of A1C will allow screening for pregestational diabetes at 12 weeks gestation. What is she? She is 12 weeks, yeah. However, this patient has no symptoms of diabetes, making screening for pregestational diabetes unnecessary. And she's glucose tolerance test is done at 24 to 28 week gestation to screen for gestational diabetes. So care can be taken to avoid complications during pregnancy. This patient is only 12 weeks.
So GTT
Um,
done in 24 to 28 weeks and HbA1c is done at 12 weeks.
no, I think there's, if I understand, they're saying that if she already has risk factors for
Diabetes.
diabetes, then the first prenatal visit you just do the A1C,
Okay.
and if she develops, I guess
Gestational diabetes mellitus.
I'm guessing, then at 24 to 20 weeks you do the
24 to
glucose.
28 weeks, isn't it the routine GTT
Yeah,
done in
yeah,
every woman?
yeah. I think it's just the routine GTT. Yes, yes. So if she has risk factors, then you do the A1C initial prenatal visit. And if not, then you just do the routine GTT at 24 to 28. I think that's what they need.
And for Rh negative mother, we will do this indirect antiglobulin test.
So RH negative mom, yes, uh-huh. Mhm.
This is not like any trimester thing, like, or it is
I
done
don't
in the
think so.
first prenatal visit or second
I
prenatal.
think it's the first. I think it's the first prenatal visit if the mom is RH negative.
Okay,
Mhm.
I'm talking because I'm trying to clear my concept. So sorry for that. Okay,
What do you mean? Oh,
like for like discussion makes the conception clear. That's why.
yeah,
Okay.
definitely. Yeah.
A 22-year-old woman comes to the physician for counseling prior to. I need counseling. Okay. Physician for counseling prior to conception. She feels well. She is recently married and her husband wished to start a family. Her husband wished to start a family immediately. Mm, She has 10-year history of type 1 diabetes mellitus treated with insulin pump. During the past 3 years, she has during the past 3 years she has been hospitalized twice for ketoacidosis. She is 163 centimeter, 5 feet 4 inch tall, weight 50 kg, BMI 19 kg per meter square. Physical examination shows no abnormalities. Her serum glucose concentration is 180 milligram per deciliter in the physician's office. Which of the following measure will have the greatest impact on the success of this patient's pregnancy? Okay.
I feel like it's adding. Okay.
The only thing that makes sense.
Okay. I thought it was adding an oral one. Okay.
Oral only
Type
metformin is given for in pregnancy.
only metformin. Okay.
Okay.
Thai glucose control during conception and
But she's
pregnancy.
on insulin. Okay, metformin cannot be given.
Oh,
Because
Thai.
he is type 1 diabetes mellitus. There is no insulin.
Oh, sorry. Oh, yep, yep. You know what?
So
You
oral
see, that's
oral hypoglycemic agent is not gonna work in here.
true. That's true. Now yeah, you see, that's what happened during the exam. You don't have time to think about those little things.
No, no, there is plenty of loopholes. We will. It is not possible to see all the loopholes in
Yeah,
just a fraction of a second.
yeah. Thigh
Very tough.
glucose. Yeah, because I in my mind I forgot the whole type one, type two. I was just like, okay, yeah, but that it makes sense. High glucose control during conception and pregnancy in a patient with pre-gestational diabetes, type 1 or type 2, is important in minimizing the effects of hyperglycemia on the fetus. HPL, human placental lactogen, produced by the placenta increases maternal insulin resistance, especially in a patient that is already insulin dependent. This leads to increased concentration of glucose in the maternal circulation and subsequently fetal circulation. Fetal hyperglycemia in turn causes the fetus to produce a lot of insulin as well as decrease the rate of gluconeogenesis. The insulin acts as a growth factor, leading to macrosomia and inhibits the production of surfactant, which leads to NRDS. Oh, so it's the insulin that does that, not the glucose. After birth, the fetus will synthesize excess insulin but is no longer exposed to maternal blood glucose concentration, which leads to hypoglycemia. Other complications associated with diabetes during pregnancy include congenital malformation like cardiac caudal regression, fetal demise, preeclampsia, preterm labor, intrauterine growth restriction caused by uteroplacental insufficiency, maternal mortality. It's not see prenatal should be recommended to minimize risk of congenital malformations such as neural tube defect. However, this patient will still be at risk of the complication of poor glucose control during pregnancy. Mm,
Okay.
okay.
A, se- a 47-year-old woman comes for a routine health maintenance examination. She smoked one pack of cigarette daily for 30 years, but she quit 1 year ago. She has had one lifetime sexual partner, has not been sexually active for 3 years. Physical examination, physical pap smear and mammography showed normal findings 8 months ago. Her mother died. Her mother died of breast cancer at the age of 60 years. Physical and pelvic examination shows no abnormalities. Which of the following is the most appropriate screening test?
Colonoscopy is 50, right?
Sorry,
Okay.
colonoscopy.
Colonoscopy
Yes,
is
usually 50.
okay. She don't need no pap smear, no mammogram. She just did it 8 months ago. Colonoscopy is 50, so she doesn't need it. An X-ray of the chest. She smokes, but it's
Pap,
not
the pap smear is done annually.
the pap smear 8 months ago. She did
Like
pap smear.
usually pap smear is done in how, like the interval of the pap smear.
I thought it's every 3 years.
Every three.
Um,
So, so just mammograph.
unless it's X-ray for the chest, but
Why
yeah, she doesn't.
X-ray? X-ray chest is
It's
not
not.
an option. Low dose CT can be
It's
done for lung cancer, but
yeah,
after 50,
yeah, yeah. Okay, ready?
yes.
So no screening indicated. Screening tests are used to identify potentially treatable conditions early in the course of to prevent long-term morbidity and mortality. Cancer screenings are an important item of discussion at health maintenance exam. The decision to perform screening tests for malignancy is based on the age of the patient and whether they have an increased risk for a specific cancer. Screening tests also decrease in value the more often they are performed. For example, this asymptomatic patient would not benefit from repeated pap smear or mammogram since they were done like 8 months ago. Screening for colorectal cancer should begin at 50 in this patient and lung cancer at 55 based on the USPSTF. Okay, which one were we confused? Oh, the X-ray of the chest is not used as screening for lung cancer. It will recommend low dose CT scans as the screening test for people that have 30 pack years smoking history, are between 55 and 18, and are either currently smoking or have quit smoking in 15 years. This patient, yeah, doesn't meet that. It is not colonoscopy every 10 years at beginning at 50. Okay, next.
Okay. A 30-year a 30-year-old multi-gravid woman at 37 weeks of gestation is admitted in labor 6 hours after the onset of regular uterine contraction. Her vital signs are within normal limit. Physical examination showing no abnormality by abdominal palpation. Her fetus is thought to be breeching presentation. Her amniotic membrane are intact. Her cervix is 2 centimeter long, 1 centimeter dilated. Presenting part is at 3 station. 3 station, but it's difficult to palpate. Ultrasonography shows a double footing breech presentation. Double footing breech during labor. Which of the following is the greatest risk for which of the following complications? Double footing.
Ready?
Okay.
So it's the prolapse of the fetal umbilical cord. Fetal malpresentation occurs when any of the portion of the fetus besides the occiput presents as the cervical os. The malpresentation prevents the head from properly engaging in the pelvis for descent. This can similarly occur in polyhydramnios, as the excess amniotic fluid can prevent any body part from presenting at the cervical os until the rupture of membranes has occurred. Serious complication that can occur in fetal malpresentation is umbilical cord prolapse because of the lack of occipital engagement at the cervical os. The cord can protrude to the cervix following the rupture of membrane before the fetus descends into the pelvic opening. Further contractions can cause the cord compression and fetal hypoxia. Given the high risk associated with vaginal deliveries in the setting of fetal malpresentation, delivery is usually completed via elective C-section when the condition is known. Cord prolapse, however, is an obstetric emergency requiring immediate C-section. It is not CNE. Postpartum hemorrhage is most commonly caused by uterine atony in the setting of macrosomia, multiple gestation, prolonged labor, uterine infection. Can also be caused by cervical or vaginal tract laceration um, and retained products of conception. Uterine rupture occurs when the muscular wall of the uterus tears and presents with severe abdominal pain, hemodynamic instability, and loss of fetal station. Risk factors include previous C-section deliveries and induction on labor, not breech presentation. Okay, thanks.
A 37-year-old woman gravid to para 128 weeks of gestation comes to the physician for routine prenatal visit. She feels well. She feels well, and her pregnancy has been uncomplicated. Amniocentesis or karyotype is at 16th weeks of gestation, shown no abnormalities. She received raw immunoglobulin. She has gained 8.2 kg. During her pregnancy, her blood pressure is 135 by 78. Fundal height is 29 centimeters. The fetus is in a longitudinal lie with a cephalic presentation. Fetus is a longitudinal lie with a cephalic presentation. The fetal heart rate is 160 per minute. The patient's Blood group is A, Rh negative. 2 days ago, serum anti-D antibody titer was negative. Which of the following is the most appropriate next step? Rh.
I don't understand. What is the issue?
A blood group, uh, he is Rh negative,
Okay, but they already gave her the
but
immunoglobulin.
anti-D titer, yes, but anti-D titer is negative. That means the anti-D titer has not reached his limit.
Antibody. Oh, oh,
You got
oh. Okay, that's what you're trying to say. Okay.
maybe
Um, maybe
maybe
we.
another shot of Rogam should be given.
Oh, you think so? Okay.
What is your thought?
I don't know. I didn't understand the question like that. Okay, but I guess yeah. I think maybe wait. I don't know. I don't know.
There is no time to wait. 28
There's no.
weeks of gestation.
Okay.
Like
Okay.
this anti-D is given probably in 28 weeks and just before the birth, within 72 hours, isn't it?
Mm-hmm.
So as he has given anti-D, but anti-D titer is negative. As titer is negative, so we need to give another shot.
Okay.
Okay,
Mm.
I'm assuming.
Administered RH immunoglobulin. Administration of another, I guess, another shot of RH immunoglobulin. RH negative moms are at high risk for developing anti-RH antibody if exposed from RH positive fetal, which commonly occurs during delivery. If RH antigen from the fetal circulation enter the maternal circulation, it's possible for the mother's immune system to form antibodies against the RH negative RH antigen. While this carries no significant complication with the initial exposure, a subsequent pregnancy with the RH positive fetus can result in severe hemolytic anemia, blah, blah, blah. We know all that. Rh immune globulin acts by binding, blah, 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 preventing immune system from developing antibodies. Administration of Rh immune globulin is typically performed for Rh negative mothers at 28 weeks gestation and following the delivery of a Rh positive newborn. Any invasive procedure, amniocentesis, and oh, they did amniocentesis. Okay. And any episodes of fetomaternal bleeding. Where did I do? Okay, yeah. RHD immune globulin is ineffective in a patient that has already developed Rh antibodies. So they did amniocentesis at 16 weeks and then they gave the Rh. Okay, okay. So it's not
Can you
repeat.
read the option B? Okay, use start with the
Oh, okay. Repeat
A.
serum anti-D antibody titer in 2 to 4 weeks will determine the patient had developed alloimmunization in that time frame. However, it is more important to prevent the development of antibodies with the administration of Rh immune globulin now, as the patient is at 28 weeks gestation. I thought they already gave him Okay, they already gave him antibodies. Okay. Clear Bedkit acid elution test is used to quantify the amount of fetal blood to which the mom's circulation has been exposed in order to determine the adequacy of Rh immune globulin dosing. It is frequently used when the Rh negative mom gives birth to a Rh positive child. Okay.
Can you
Rh,
explain the option like the answer in simplified manner?
What, like this answer?
Yes, yes.
Oh, it's what you just said. Like, it's what you said. The reason you gave, like, because they gave her the immunoglobulin, but it says that she's negative. She has
She has amniocentesis. So, like any kind of this kind of invasive procedure, like amniocentesis or any fetal-maternal bleeding, we need to give another dose of ROGAM, like RH immunoglobulin.
no. She had amniocentesis, so
Okay,
they gave her the immune globulin. So they
okay,
did their part. She had
yes,
amniocentesis. They gave her to prevent it. But it's what you just said that it seems like even if they gave her the immune globulin, the immune she doesn't have immu- the immune globulin. She doesn't have the antibodies
okay,
that says that, oh yeah, the immune globulin work. So then we give it again.
okay.
I think that's what I mean. Yeah.
Okay, next.
Hmm.
A 27-year-old woman, a 27-year-old woman at 22 weeks of gestation is admitted to the hospital because of fracture of the right ribs, 4 to 10, sustained in a motor vehicle collision. She is intubated. Her blood pressure is 120 by 80. Her urine output is 50 ml per hour. Fetal monitoring shows fetal heart tone, hematocrit 30, leukocyte count 9,500, platelet count 70,000, prothrombin 16, PTT more than 100, fibrinogen is low, PTT high. PT is high, PTT high, low fibrinogen. So looks like okay. Fibrin splitting product are present in the serum at 1:1 160 dilution. Titer ultrasonography shows free fluid. Which of the following is the most appropriate next step? Looks
So
like
both
DIC.
so both PT and PTT are high.
And fibrinogen is low. Fibrin splitting product is high. Looks like DIC, isn't it?
Yeah, but the question is asking what's the most appropriate next step.
DIC.
Ready? Yeah.
Okay.
Is cesarean removal of the fetus, or C-section. Antepartum intrauterine fetal demise commonly presents with decreased fetal movement and lack of fetal heart tones on exam. Ultrasound confirms the lack of cardiac activity and the death of the fetus. In high-income countries, stillbirth is most commonly caused by chromosomal abnormalities, uteroplacental insufficiency, maternal medical disease, whereas it is more commonly to it, whereas it is more commonly to the result of maternal infection, preeclampsia, or obstructed labor in low-income countries. It can also be caused by significant blunt abdominal trauma leading to probable placental abruption or uterine rupture, as in this patient. Delivery for antepartum intrauterine fetal demise is based on mother wishes, with immediate induction or delayed natural delivery both feasible options in the absence of any complicating medical issues. Labor typically begins 1 to 2 weeks after fetal demise. Coagulation abnormalities can occur with delayed delivery because of the release of tissue factor from the placenta. This can lead to DIC, um, okay, which presents with thrombocytopenia, prolonged PT and PTT, increased D dimers, and decreased fibrinogen. Um, As this patient has developed DIC based on her lab abnormalities, urgent delivery of the fetus is needed. However, as she is intubated and not in active labor, C-section. Hmm. is the most appropriate next step. I never understand these things, like the
Fibrin,
160. What?
fibrin,
No, the
fibrin degradation product.
no, like when they give that 1.160, when they
Uh,
give those,
like
what that
do you understand the Vidal test
no,
done in typhoid fever?
no.
Like usually dilution maybe 1 is to 80 or 1 is to 40, then 1 is to
Mm-hmm.
160. In Vidal test, what we see actually this kind of titer. Like if the titer rises, you can start, you can think that it is the normal value is 1 is to 80. Then 1
Mm-hmm.
is to 160 is more. So there is increase. So if titer is increased, then chance of having that condition is much more. You got my point.
So if it's higher than 1 to 80, so if it's 1 to 81, 1 to 90, that means that it's increased.
No, that means it is normal. So if it rises like 1 is to 160, so the titer is raising, so it means it is significant. For looking at this titer, it is not confirmatory. If you look at this dilution titer, it is not confirmatory.
Okay, so here if it was 1 to 50, that means that fibrin spike products are decreased.
Like it it is not significant. Like fibrin degradation product may be present in the serum, but it is not significant.
But because it's higher than 1 to 80, that means that it's significant.
Significant, yes.
Okay. Okay.
Okay,
It
can
is
we
not
stop? Okay,
okay.
yes.
Sorry.
You
It's
read.
not exchange. It's not exchange transfusion because that's used in sickle cell disease. Occasionally, in severe unconjugated hyperbilirubinemia of the newborn to reduce concentration of hemoglobin S and bilirubin, respectively. It does not play a role in management of DIC. Platelet transfusion is when it falls below 10,000 without evidence of bleeding or below 50,000 with active bleeding. Transfusion of packed red blood cells is when it falls below 27 hematocrit. Oh, sorry, 21% hematocrit. Yeah, okay. You said we can stop here and you want to do the biostats.
Yes,
We were at, I'm guessing it's measures of dispersion. I think we did measures of central tendency.
yes.
Yeah, yes, the measures of dispersion. Wait, which one is the answer and which one is the, I forgot. Let me see. This is question and answer. Okay. Open with preview. Okay, it's only two.
Okay, you start reading. I haven't found yet.
Okay,
Find.
force. Okay,
You start reading. Measures of what? Measures of dispersion. Yes.
dispersion. Mhm.
Measures of.
Four separate
Yes.
studies are undertaken to assess the risk of um, 4 separate studies are done to assess the risk of acute coronary syndrome in postmenopausal women taking hormone replacement therapy. The results of the individual studies, as well as the result of a meta-analysis, are shown on the table. Each study result is presented as an odds ratio along with a confidence interval. Which of the following results most likely corresponds to the meta-analysis? A, B, C, D.
Of. If it touch 1, then it is significant. What we are looking for?
Here, I do not know. I don't know what
You are
it is.
very good at Bastet.
Mm,
Find something, find any clue that we can think about. What they are
uh,
looking for. Each study result is present
oh,
odds ratio, case control odds ratio.
they are asking for the meta-analysis. So the meta-analysis is
Hmm.
um, all, a bunch of studies put together. So the power should be higher. So the confidence interval should be smaller. I'm thinking that's what they're trying to say.
Okay, next.
A study addresses the role of air pollution in asthma development. 100 children with diagnosed asthma and 200 children without asthma are asked a series of questions regarding their homes. An air pollution index ranging from 0 to 10 is then calculated based on each child's response. The mean air pollution index for children with asthma is calculated as 4.3. 95 confidence interval is significant. Which of the following statistical changes would be most likely if more asthmatic children were included in the study? So if we add a more asthmatic children, okay, standard error of upper limit will decrease probably. Lower limit will decrease also.
95% of 4.3.
Okay, and then standard error of the mean, it will decrease. So you see, if why is it like this? Okay, ready?
Yes. Okay, I'm
Okay,
reading the explanation.
let me see. Okay,
Range, range, 24 is D, you are right. Range, standard deviation, and standard error of mean and the percentile, all measures of dispersion or variability. Range represents the difference between the highest and the lowest value of the dataset. Range represents the difference between the highest and the lowest value of the dataset. Standard deviation measures dispersion around the mean in the study sample, whereas standard error of the mean show how precisely the sample presence, how precisely the sample represents of the study population. Uh, ACM, what is the full form of ACM?
standard error of the mean.
Okay, sorry. Standard error of the mean is always smaller always smaller than the standard deviation because it is calculated as standard deviation divided by the square root of the sample size. So standard deviation is calculated in how the standard deviation where standard deviation represents the standard SD standard deviation. Sum is the sigma means the sum of the value. X represents the individual values of the data sets and capital X is represents the mean. N represents the number of the data points in the set. Note that N is inversely related to SD. In other words, as the number of the data points in the set increases, the standard of the mean decreases. As noted in the section of the confidence interval, the formula of the confidence interval is as follows: 95% confidence interval, mean plus 1.96 standard deviation divided by root over n. In other words, confidence intervals vary directly with the standard deviation and inversely with the sample size. In other words, the sample size increase, the confidence interval decrease. The sample size increase, the confidence interval decrease. Narrows. Applying this principle in question 1, a meta-analysis contains more data than any of the individual studies from which it is when it is derived. Since the sample size is larger in the meta-analysis, the confidence interval will be the narrower. Hence, the correct answer is D. Also apply question 2. As the number of the data points in the set increases, the number of the asthmatic children the same, the standard error of the mean decreases and the confidence interval narrows. Can you explain? The answer is written in the last, in other words, in the last para.
Hmm?
Can you explain?
Which one?
Both.
Um, I think
In
they're
meta-analysis, yes.
saying that they're going by this formula, the SME. Oh my goodness.
Standard deviation equal to.
No, is that one? I don't know which one is what's the top, but I think it's standard deviation. Yeah, I think the work. Wait, the standard deviation over I think is the square root of n. So
Okay.
if n is going up, then the error is going down, like it's inversely proportional. So here they are adding meta-analysis has more data, more n. So then the error would go down. Okay, I don't think this one doesn't apply to, but basically if you get a more sample population, then your cost confidence interval is going to be more tighter. Does that make sense?
Yes.
Yeah, because you get more people, so your results are more
Accurate.
accurate. Yes, yes, you got it, more accurate. So that's what they're saying here, that here you did like 4 different studies, and then they compare your 4 different studies to a meta-analysis. But meta-analysis is a combination of like, I don't know, 100 studies or whatever. So obviously the accuracy is going to be more than your. That's just like four different studies. So if the accuracy is more, then the confidence interval is going to be more significant. And you already know that if it includes one, it's not significant. So you already know A is not the answer, C is not the answer, E is not the answer because they include one. So then you're left with B and D. But then B, look at the confidence interval, it's pretty big, pretty long, whereas D is shorter. So it's a tighter confidence interval. So you know it's D. That's kind of what they wanted to do. And for this one, it's kind of the same thing. They're saying that you're adding more numbers to the asthmatic population. So this one is going up. So this one will go down. This is what we get here. Standard error of the mean is going down. The confidence interval, you already know, is going to be tighter. So the upper limit, the confidence interval is usually here and here. It has 2 numbers from, what is it? Oh, right here. It's already 3.1 to 5.5. So it's going to be tighter. So the 3.9, 3.1 is going to go to the, how can I explain that? The 3 is going to be tighter. So less than, does it make sense? I don't know how to say it. Though it's going to be
Like
tighter. So
upper limit should be lower,
will be lower, and the lower limit should
should be
go down.
upper. Well,
To be upper.
no,
Yes. So you
upper confidence interval is should be lower and lower.
uh-huh.
Okay, got it.
Yes, yes, yes. So
So
it should.
both
So it,
should they both should come closer. Like 3 point
so yeah,
if it is 3 apart from 3.5, if it is 3.8, that
yes,
means lower limit is getting upper, and 5.3 if it comes closer to 5, then lower, like upper limit is lower. I got it.
yes. You got it. Yeah, yeah. It's going to be tighter. Yes, that's kind of. So it was all based on this, on the fact that you add more numbers to one to the population, so you make the confidence interval tighter. Yeah. Mhm.
Standard error of, okay. So this the same divided by same SD divided by sample size. Okay, the first line I got it.
Mm-hmm. Yeah, you don't need to memorize the thing. It's just to, yeah, just to know that it one, if one goes up, the other one goes down. That's
Okay, okay, that's all for
all.
today.
Um,